Um, okay, good morning, everybody. Good evening. Welcome to the FND Hope webinar. Very happy to introduce Dharsha Navaratnam to you. She's a physio working at the Mater Hospital in Brisbane. So we're going to follow the usual process where you can ask any questions in the chat. We're just going to begin with a little bit of an introduction by Dharsha. She'll tell you a little bit about herself and we'll ask a few questions, and then we'll move over into general questions. So for the people out there, if you can just maybe say hello in the chat and just so that we know you can hear everything okay with us, that'd be great. But Dharsha, I'll hand over to you now and let you just explain a little bit about your background and how long you've been working at the Mater.
Brilliant, thanks for that. Thanks for everyone for tuning in this morning and this evening as well. So I've been a physio for 10 years now, working predominantly in neurosciences and rehab. So officially I started off with the F&D clinic at the Mater Centre of Neurosciences in April 2015. But I dare say all my career I've been working with F&D patients. They've just been not labelled or not diagnosed correctly. My first memory was probably my second year out 8 years ago. So at the moment in my current role, I'm fortunate to be the team leader of Neurosciences for Physio in a joint and mixed public and private model of care within our private practice and also in inpatient setting at the Mater private hospital as well.
Yeah. Okay, no, that's great. And what's been unique about the Mater and the program that's been set up there? How does that differ from obviously what you experienced before, kind of working independently?
Yeah, so I'm in a really fortunate position. Dr. Alex Len came to the Mater with a vision. He has a movement disorders clinic over at one of our neighbouring hospitals, and he was very passionate, is very passionate, and he's approached the Mater to set up a F&D clinic. And so he got the go-ahead. He's got half a day a week. It was the amount of funding he got, which we're very grateful for. And then he approached myself and the neuropsychologist at the time, Dr. Rian Dobb, just asking if we were interested at all to be a part of his clinic. And we were definitely very interested in seeing how we could make a change and how we could contribute to the service. Particularly from a physio perspective, I was quite intrigued because traditionally in the past, it was always handled as a psychiatric disorder, that physios didn't really have a place with this disorder. So based on my history up until that point, which I'd had some involvement with some patients, I was intrigued to see how I could apply my neuro skills to the case mix.
Okay.
And so to answer your question as well, what makes us so unique is we work together quite closely. So individually we're quite passionate, but then as a team, we're very passionate to get the best out of our patients. And in terms of community education as well, we get invited to provide education at a local and interstate level as well, which is good. We know each other, we know how each other works, and we case conference with each other every 2 weeks as well, which I think is what sets our clinic apart from usual care.
Yeah, so it's very intense sharing of information then share the knowledge. And in terms of the patients that come through the program, is there any patient that it doesn't work for, or is there anything that marks a patient out as being sort of, yes, we'll know that we're going to have more success with this patient over another type of patient?
Definitely. We'd like to think that we can make some improvement to all our patients that come through the clinic. A good analogy, which is reflective of the literature as well, and it's in line with our recent audits, it tends to fall into thirds. So there's probably about a third of our patients who we make real life-changing, like positive changes for, and they go on from not being very mobile to going out and engaging in the community again, returning to work. So those high-end outcomes. There's another third that we do make some positive impact to quality of life, and we do make some impact to movement as well. And then unfortunately, there is also a third where we don't make as good a difference as we have to the other 2/3 of the group. And looking at our audit findings as well as the literature as well, the common themes is mainly acceptance of diagnoses and understanding of the diagnoses, and also extensive comorbidities, but primarily with extensive psychiatric illnesses as well. There's a whole stack of other prognostic factors as well, like chronicity, age, particularly chronicity and how complex the presentation is, but definitely that understanding of the diagnosis seems to really, there seems to be a big switch there with how far the patient can come across with their outcomes.
Yeah, and that's an interesting position, isn't it, for patients to understand, because I know from talking within our own patient community, people will say, well, I am still quite accepting of my diagnosis, but I feel like I'm getting worse. So there's more to just accepting the diagnosis. I think there's one of the things that, and I don't know whether this is proved through the sort of audits and research that have been done, but the opportunity to work with professionals such as yourself who were so supportive, it's a symbiotic relationship, isn't it? It's the positivity that you can express helps the patient because they want to get better, and so it confirms everything in a way. Is that something that you've felt that's different? As you said before we started this session, you'd worked locally without the support of such a great team. Do you see now that you're more successful because you've got this bigger team around you, which is all professionals dedicated to, solving it?
Definitely. So outside the clinic, I'm in a really fortunate position that I work within the clinic, but also external to the clinic currently as well. And there's definite differences between working in this isolated, dedicated team versus managing patients external to the team as well. I think when patients see you confident and have that physios have an understanding of what the disorder is as well, I think that even starts the process of the plans to see that starts I feel starts firing the nervous system, just knowing that you can place your trust in a therapist that knows what's going on, and they're not thinking that it's in your head or that you're crazy as well.
Yeah, no, absolutely. And the other question that I had, and I'll stop asking questions and we'll throw it open into the chat. In terms of success, again, a lot of our patients are concerned about the duration that they might have been suffering symptoms for. If they've had a diagnosis maybe 8 years ago or 10 years or more ago and they're still suffering, whether they'll ever get better. Do you see the people that are coming through your treatment program that have been long-term are still able to make a good difference?
Yes, definitely. So again, they're probably not the big drastic changes after 20 years, because after 20 years, even after a year, it goes from F&D to developing the secondary changes. So if you're sitting in a wheelchair for most part of the day, all the muscles are going to get shorter and weaker. So that's not just F&D there, that's also some organic changes that are going on physiologically. And so after a period of time, there's still capacity for neuroplasticity to change, but it also just takes a little bit harder work to get there. And so that's why chronicities, the longer you've had F&D, unfortunately, with all chronic diseases, the longer you have something, the harder it is to reverse. But what we do know, because there's no damage to the nervous system, there's a problem with the functioning of the nervous system, there is capacity for change there.
Yeah. Okay. No, that's good. Right, we've got our first question from Nava, and she's asked, is FND associated with particular age groups, genders? What about children? What about those who have met with accidents?
Yep. So it's a disorder that doesn't discriminate anyone, unfortunately. So it affects people of all ages. We predominantly see it from adolescence onwards, not necessarily children under in the early ages. Although, mind you, I also work with an adult population, so I'm a bit blind to the younger cohort that's there as well. But yes, it can happen. Functional neurological disorders is normally a precipitating factor that causes it. So it not necessarily psychological, but there could be a physical injury that causes it. So yes, it can be due to an accident or some other injury as well. But it doesn't discriminate between people, and there's a bit of a higher prevalence amongst females than there is against males, but it definitely can affect everyone.
Yeah, yeah. And what's been the proportion of people that have come through the program where there might not have been a physical injury, but is it more common after physical injuries or not, I guess is the question.
It definitely is more common with having a psychological aspect to it. About 55% to 60% of the patients Alex Len reviewed in his clinic were referred to physio, and about 20% of that 50%, should have worked this maths out before, didn't need psychological input. So not all F&D patients need that psych support, but there definitely is. There's no denying there can be a psychiatric component to it as well.
Yeah, and I think word psychiatric and psychology, it's so damaging to people when they hear it, but I know that there's a lot more that we can do to try and calm people down. I mean, psychiatric just means it's the way that the mind's working. It doesn't mean
I agree. I feel as well, it's all in the approach of how you explain it as well, because I know everyone is more keen to come to physio than they are to see the psychology teams. And I'm like, oh, yep, so you've met Alex, and if you haven't met Rian yet, you will meet Rian soon. And then everyone, you can see going, oh, everyone thinks I'm crazy. But the way I like to explain it is it's a mismatch between the body and the mind. And so to get both sides working together as a physio, I lack a lot of the cognitive behaviour therapy. The mind components is that mismatch. So by working together as a team with psychology and physio helps reconnect that gap that's there. And that's how I like to explain it. It's not a craziness component, it's reconnecting the two links together.
Yeah, and do you see as a physio that the way that's working with that be it CBT therapy, but in conjunction with the physio work that you're doing, you have far greater success with that approach than trying to just do physio on its own?
Definitely. I've definitely, compared to before I started working in this clinic, I compared 3 years ago, if I was to try, and I've got a bit more tools in my toolkit now to approach that, so I feel a bit more confident now. But more often we do definitely need our psychology comrades, not necessarily psychiatry, but our psychology comrades also help, and then our psychiatry comrades also help if needed as well.
Yeah. Okay. We've got a couple more questions that came in over the website. This one's from Elizabeth, and she has described that she's had F&D symptoms for 25 years, but has only recently been diagnosed. She's suffering a little bit more because of the region that she's in the US, Portland, Oregon, that there's not a lot of support within that area. She's mentioned that she's got gait issues, complex movement issues, weakness, fatigue, and some balance issues. Her challenge is that standing increases her movement disorders and activity increases her movement disorders and her fatigue. The less I do, the less random movement I have. The movements are exhausting and cause muscle and neck pain. And her question is how do I work toward correcting my gait, and how do I increase my activity without seeing myself going backwards? Which I guess is a fairly common thing, yeah.
That's a great question, Elizabeth, and it's very, very common, fatigue management and management of symptoms with rehab as well. Physios get really excited when we see weak muscles, that we want to over-exercise things a lot. So a great place to probably get started is even lying down and starting some exercises there. Starting with really low reps. For example, sometimes I'll give some of my patients 1 or 2 of a certain exercise to do 3 times a day, and that's it to start off with. Because when your endurance is very low to begin with, if we start giving exercises up here, it's like if I was personally to go for a 10-kilometre run. I can't run 10 kilometres, so I'd achieve it, but then I'd crash the next day. So every day I've got to do a little bit more in order to get to that 10-kilometre mark. And so if standing up in itself is quite tricky, I would start with exercises in a lying down position or a seated position, build up that endurance there, and then see if you can work it in a different position there as well.
Yeah.
But yeah, low reps is, I think we're in a society of if you don't move it, you lose it, and you hear all those sorts of phrases quite a lot as well. With fatigue management, it is quite a graded progression towards achieving goals. It takes a lot of hard work and dedication, but it is a quite graded approach.
Yeah, and if people do find that they've gone backwards and feel that things are worse, what's the right approach to recovering from that? Do they stop everything and just rest, or is there a more gradual way to get back to where they were?
Yeah, great question. It's different for everyone. So everyone's probably very used to hearing it can vary from person to person. When patients go through our program, from day one, we talk about relapsing. So there will be a stage where you're feeling good with your symptoms. However, until we've managed what the warning signs and triggers are, unfortunately, you will be prone to having relapses of your symptoms. Some people need a day without their exercises and they can resume slowly the next day. Some people need a bit longer. Some people as well, and this is where our psychology comrades come into play, is when they start to recognise their warning signs that they're having a relapse, that they tap into their mindfulness strategies, any psychosocial activities as well that can help de-escalate some of the warning signs that are going on. But yes, in terms of once the relapse has happened, it definitely varies from patient to patient, but we recommend trying to get moving as soon as you can, but also taking some time out as well.
Yeah, okay. We've got Sian in the chat and she's put her hand up. I'm just going to promote her to panelist so she can ask a question directly. So
yep,
you get that to work. Okay. Sian, if you're there, you can go ahead and ask your question.
Hello. My question is, I've found that particular neck movements trigger severe dizziness, and they give me a loss of coordination and ability to speak. But then I found a warm beanie on the neck restores my speech and other symptoms after about 10 minutes. Could you explain what may be happening and why this happens?
That's definitely a very interesting presentation there. It's the fact that it's the beanie. I'm sure you've been to get assessment and things have been ruled out as well. But the fact that once you put the beanie on, that there's already signs of reversibility, that's a good sign that it leads that towards that it's a functional neurological disorder. Why that happens? Good question, and I wish I had a steady answer for that, but it could be that that sensory input there is the input that's needed at that time to help relieve whatever's going on in that area. It doesn't necessarily mean that the muscles are stuck in that position and that tactile input is undoing or changing anything there, but it can just provide that input it needs to reverse what's going on there.
Okay. I haven't had any check on to do with my neck or anything like that. Should I ask for that, or?
Well, I always think it's good to rule out, because having a functional neurological disorder doesn't make you immune to having other disorders, stiff neck or anything else as well. So people with other neurological diseases can have FND. People with neck pain can have FND. So it just because you have FND doesn't exclude you from other things. So me personally, I like to rule out the things that I can rule out from a physio perspective. So with regards to your neck, making sure we can rule out any muscle weakness or joint stiffness. And even though that might not be causing what you're going through, it might be contributing a little bit to what's triggering your symptoms as well.
Okay.
So I definitely think it's worth checking and clearing, but also see, and then that way you know that there's nothing underlying secondary that's happened as a result of FND as well.
Okay, thank you ever
so much. I hope I've explained that well.
Thank you very well, thank you.
Thanks for the question, Sian. That's great.
Yes, thank you.
Okay, I'm just going to try and put Sian back in the rest of the thing. So, yep. Okay. Now, another question that we've had, this one comes from Alison. She said, I went through an intensive treatment program over a year ago, but had a relapse due to a large change of stress in my life. Do you think I would benefit from repeating a program? I am still in much better shape than I've been in prior to treatment. I've had FND for 17 years, and the intensive treatment program was the single most effective treatment I've had.
Well, that's great to hear that there was a service available that was intensive like that. I'd say reflect on the tools that you got out of that program. It's good to hear that you haven't gone completely backwards, that you're at a stage where you've still retained some of the improvements. But some of the key principles we try to foster from day one is reflection of symptom presentation. What are the warning signs? What are the triggers? And what we can do to help manage those warning signs before it gets to a relapse. And then also, once there is a relapse, what are the strategies that work for you as well? So I wouldn't say not to go through the program again, because it sounds like it did really, you got some really good outcomes from there, but seeing if we can reflect on what the strategies and tools that you got out of that program and seeing if you can apply it to current day. And it might be a different presentation, but normally the core principles still can apply.
Okay, that's great. Another question here from Beverly, and she's asked for an explanation of how is FND physio, or neurophysio, different from regular physio?
Yeah, great question. Technically, there shouldn't be a difference, but the approach is that we focus a lot on automatic movement. There's an understanding that the nervous system, there's a problem with the functioning of it as well, that when you try and overthink a task, sometimes it can break down that the actual success rate of achieving the task. So I think from a neuro perspective, the pros with seeing a neurophysio over any other physio is breaking down the individual components of the movement and trying to problem solve how to achieve that movement there as well. Yeah, the crux of it is trying to get that automatic movement and doing the thorough assessment to see if we can treat any secondary changes there as well. But it definitely is skills that, definitely are skills that all physios can have, but it's very experience-based driven as well.
Yeah, and I think there's a distinction as well, isn't there, even within the world of neurophysio, where people who are used to working with sufferers of a stroke will still not have the relevant expertise to do with someone with FND. Yeah, no,
I completely agree with you there. I think it definitely, I feel FND is very experience-based. I know when we do our lecture series, when we go to different sites, I often feel that I'm explaining something that feels very, very basic, just the principles of it. But when you actually apply it, I know I draw a lot on past experiences just to know what's worked, what hasn't worked, and then go from there. But I definitely don't think an inexperienced physio can't help in some degree as well.
Yeah. Okay. Another question here. This one is anonymous, but the question that's been asked is: can FND be a secondary condition to a pineal gland cystic lesion?
Yeah, so FND can be associated with anything. So we often refer to if there's an overlay with functional neurological disorders. So, for example, that will probably have quite an impact on your sleep cycles as well, and other hormonal changes as well. But the changes in your presentation that can't be explained by the pineal gland that would be what's caused what they would label as FND. So yes, like I mentioned before, just because you have an organic disease, doesn't exclude you from other disorders, including FND, and having FND doesn't exclude you from other organic diseases as well.
Yeah. Okay. Great answer. A question that just come through in the chat from Jacinta. She's asked, I've been suffering from FND symptom relapses for 12 years. When going to the doctors before, I've always been told to just try to ignore and get on with everyday activities. This relapse I found I waited a little while when the symptoms first started due to this treatment from the doctors. Do you suggest that when movement problems start that we should push for physio as soon as possible?
I would definitely say yes. Coming from a physio myself, I'm definitely biased. I think if there's something movement related, it's always good to seek a physio. I think part of the gap in, I think, the services worldwide is the lack of awareness and education regarding FND, and knowing that because it is a movement disorder, that physios, as movement specialists, we do have a huge role that we can try and break down what's going on, at least see what the triggers are with regards to the movement signs as well. So if there are changes, or if you haven't seen a physio yet, I definitely recommend that you go see one.
Okay, that's great. And there's another question here that came in through the website, very similar. And what she's described here, she says, my daughter shakes each time she eats. It doesn't stop until she takes 2 Panadine Forte. She's seeing a neurophysiotherapist today. We are not sure if it is FND causing it or an eating disorder. This has been happening for 18 months now, and she has no social life because of it. She's 35 and has had FND for 18 years. She had a similar thing happen some years ago, but it didn't last this long. Do you think neurophysiotherapy could help? She has other issues, loss of leg strength and speech issues at present. So sounds like a real mix of typical FND symptoms there.
Yeah, and I think that's the crux of FND. It can present quite simply, but it can also present quite complex as well, with a plethora of symptoms there. I still think, and this is coming from someone who's experienced with FND and is very comfortable with FND, even with eating and the tremor there's definitely a role for physio, because more often than not, there are physical triggers that are causing this. It could be pain, it could be fatigue, it could be an element of frustration, which I know isn't purely physical, but it does impact physical performance as well. And there are definitely, when the arms and legs aren't moving in the way they're supposed to, it's those secondary changes that I think physios have the biggest role in, because if your arm's constantly moving, that's not normal movement. And so there's got to be something working too hard and something not working hard enough. And a physio's role is to turn this one down and get the core muscles working up a bit harder as well.
Okay. And on that point you just made about pain, a lot of people are suffering with chronic pain. How much of an impact does that have in terms of successful physio treatment? Because people will hit their limits a lot sooner if they're in chronic pain all the time.
Definitely. Physio chronic pain models is very similar to the FND neurological model as well. It's all graded, it's paced. It can be, I know we find it tricky in our clinic, being a neurology-based clinic, when there's quite complex pain presentations that they've been on 5 to 10 medications for the past 3 years. It's difficult to know, because you need to be properly medicated to be able to do the exercises. But at the same time, what we know about chronic pain and central sensitivity is that more movement and the more the brain knows that it's safe movement, can start to wean down some of the pain as well. The tricky thing is with long-term pain, especially when it's chronic, is that there's lots of neuroplastic changes that have already occurred. But then again, the positive thing with that is that it's with neuroplasticity, there is that element of reversibility. So it definitely adds that. Fatigue and pain are the two things that are at the biggest levels of complexity in our case mix. And I definitely agree that it needs a lot more research and more awareness of what's going on with pain, and more unified ways of approaching pain as well, not just with medications, and right from the word go, not 10, 20 years later.
Okay, no, that's good. We have one of your fans that you've worked very successfully with, Julia Wright, has just wanted to ask a question, and she's doing it on behalf of, obviously, a lot of members that asked the same thing. But retraining the brain is a phrase that we hear a lot about. Julie's just said, could you explain what retraining the brain entails from your perspective as a physiotherapist?
Yeah, that's a great question, Julie. So what we mean from a physio perspective is, what we know about the brain is that it's capable of change. no matter what the injury is, like even if it's functional or not functional, the brain has capacity to change. And by promoting neuroplastic movement that means something to the person, and it's not just people with FND, it's with anyone. If I was to try and learn a new skill, it'll be the way that I would learn the skill is through practice, repetition, making sure it's meaningful. So then all the neurons and the hardwire of the brain start to reconnect as well. So when we talk about retraining the brain, it's trying to dampen down some of the I don't want to say negative thoughts, but dampening down the unnecessary things that are getting in the way and promoting the things that we can really foster and encourage there. And Julie, I hope you don't mind me saying, Julie was a really great example of how consistently being motivated and doing the exercises. It is hard, it's hard work, and it's hard work over a long period of time, but that constant repetition of doing the correct movement and making it more automatic does translate over time.
And
whether the changes be small or big, there is some sort of neuroplastic changes.
And is that keep that change in place? Is it something that constantly needs to be reinforced, or is it, you know, an intensive period of time, be it a month or be it 6 months or whatever the duration is appropriate, then sorts it out? What's the feelings on that particular point?
Yeah, another good question. So when we go through acquiring new skills, there's that intensive, and early on we need to practice that skill quite repetitively, and then if we lose it, I know when I was trying to learn French, for example, I feel like my cousin would disagree with me, but I thought initially I was pretty good at it, and then I didn't do it for about a year, and now I don't know if anyone can understand what I'm trying to do. And that's because I went really hard initially, and then I went a long period without doing it, and then it's trying to pick it up again. Once we start, what we know is once you do an intensive period, let it go again, but doing it consistently over a period of time, that helps consolidate that process. So with some things, yes, you do need to rehash. I guess that's where the phrase comes. It's just like riding a bike.
Yep.
Going back on it, you fall off a couple of times, but then in the end you get back on it. But it is different from person to person, of course. But the idea is once you have that muscle memory and that neuron memory there, it is stored in the brain, and it's stored there to help try and part of the physio's role is to try and regain that movement as well.
Yeah. Okay. Another question here from Rhonda. She's asked, my daughter had testing done, MRI, EEGs, when her symptoms were limited to 1 foot turning in, and the test came back negative. Her symptoms have now progressed over 2 years to what presents like generalized dystonia. She has back, leg and neck spasm involving whole body stiffness and cannot even sit comfortably in a wheelchair. The spasms are constant all day and only subside during sleep. Is this presentation unusual? And she just closes by saying, we're waiting a review with the neurologist who diagnosed FND.
Unfortunately, it's not unusual. That is quite a complex presentation of FND, but it's definitely not unusual. So the role the neurologist will have there is a diagnostic role, but I think there's definitely a role for, I'm not sure what the background is psychologically, but there's definitely a role for physio and having other multidisciplinary input to see what makes the dystonia worse, what makes it better, if it's positional, and then seeing if there's any therapies that help. I know with dystonia positioning, there's a huge role for electrical stimulation as well, and even hydrotherapy in a lot of neuro populations have a role there. So it's good that you're seeing the neurologist who's diagnosed you, but there's also some adjunct therapies that you can try there, and it's definitely not unusual, unfortunately.
Okay. This question comes anonymously, and I don't know if you'll know the answer to this question, but will there be more training for allied health services in the best way of treating FND? So I guess just from your own experiences working independently and obviously as part of the team, what you were seeing happening in the world of FND.
Yeah, unfortunately there isn't. I always get asked we'd love to know more about F&D. I get invited to talk at a lot of different places for physios because everyone's got that interest there. I'm speaking for Australia. There's no courses at the MARTA. Our current team, we're running masterclasses. So we ran one successfully at the end of last year, and we've got 2 running this year as well, and that's open for all disciplines. Our model of care is multidisciplinary, so our course is run by myself, Alex Lan, our psychologist, and our psychiatrist, and all the team members sit in all the didactic lectures, and then they all participate in the simulated actors part as well. So I know we're in Brisbane, we're driving a bit of professional development for allied health, but I'm unfortunately unaware of what's going on internationally other than the conference that happened in Edinburgh last year.
Yeah. Okay. Gemma has asked, could you suggest some recent research in FND that supports physiotherapy input and other sources that are good for physiotherapists to look at?
Yep. Glenn Nielsen in London, he's done significant and quite incredible legway with establishing physio's role with F&D. There's an open free access article that he wrote alongside the other rock stars of F&D, John Stone and Mark Edwards as well. They've done a nice paper, and it's a consensus recommendation for physios of a guide to how to approach F&D. And that's the full article is 76 pages, but they've also kindly made a 7-page version as well. So whenever I refer patients onto a different service, I'll always recommend reading that consensus recommendation as well. There's an RCT that came out in 2014. I'm murdering people's names today, unfortunately, but it's by the author of Jorbu, Jorbu. I had to write it down for a second. So that was a nice randomised control trial that looked at inpatient multidisciplinary care as well. I think all up, Alex Len has mentioned there's 22 randomised control trials based on approaching F&D from a multidisciplinary perspective. But also there's multiple case studies as well. But my 2 resources that I'll direct physios to is the Glenn Nelson's consensus recommendation, but also Explain Pain, which was a book written by the Neuro Orthopedic Institute that's based in Adelaide, and they've got a really nice approach to graded exercise programs and pain management. And like I said before, they're very similar models that I've been able to apply some of those skills in managing F&D as well.
Okay, great.
I can definitely upload that link somewhere as well if that's helpful later on.
Yeah, I think we have a link to Glenn's paper already on the site. But yeah, if you want to email me that, I'll make sure it gets up onto our website, and we can
Brilliant.
Facebook as well. So great. Kate has asked a question here. Do you think a long prior history of anorexia could damage the brain nervous system to cause FND, and can this be reversible? A lot of research on eating disorders talk about starvation damaging the brain.
I guess they're not, the one can cause the other, but they shouldn't be confused as the same. So the definition of it is that there's an intact nervous system, that there's no damage to the nervous system, and that there's a problem with the functioning of the nervous system. So it can mean that having a history of anorexia may have led to having a functional overlay, but the anorexia hasn't caused if there was damage caused to the nervous system, that's not what's caused the F&D. I hope that I've explained that well.
Yeah, okay. Sue's got a question here. She says, I went through the clinic 18 months ago and you got her walking again. She's asked, I wanted to know about how to address noise as a trigger. For example, my husband sneezed and I immediately had a seizure and then lost my speech. Is there anything from a physio standpoint that I could try?
Yep. So what I know this probably sounds outside of physio perspective, but a lot of desensitization, that's what a lot of work that we do, whether it be motion sensitivity that causes dizziness, visual sensitivity as well. It might sound a bit funny, but it's trying to desensitize yourself to different noises and different types of noises. There was a couple of weeks ago, in fact, I was YouTubing bird noises and car horns and all that, and it made quite the scene in the clinic. But that's one of the things that I prescribed to one of the patients there, was just getting a huge variety of different noises, whether it be quiet, whether it be loud. Getting someone to set an alarm sporadically as well, that can also help. But the key is trying to desensitize those noises there.
Yeah.
In a graded fashion. So we don't want to do big loud noises constantly if that's your trigger, but just trying to start small and then gradually make it more sporadic.
Yeah. And
noise exercise program.
Yeah. And obviously things like YouTube as a resource for trying to find examples of some of those noises is a great place to go.
That's it. I know for motion sensitivity, the Emory Clinic in the US, they've got a whole channel on dizziness and motion sensitivity, and they've got a whole stack of video resources there. I'm yet to find anything on noise specifically, but yes, the Emory channel, if there is motion sensitivity, those videos are quite good as well.
Yeah. Okay. We've been going for just about 40 minutes now, so we're getting close to the end of the session. So if people have got any more questions that they want to put through, get them in quickly now. We have somebody here, Bethan has noted, clearly you are passionate about FND. What do you enjoy the most about your work in this area?
That's a great question. I think what I love most about working with FND patients is that it's that capacity to change. So working in neurology, I work with a lot of patients who unfortunately have degenerative diseases, progressive diseases, nervous systems that don't have that reversibility to change. And when we are able to make significant changes in someone with FND because there is no damage to the nervous system, and there's that potential for reversibility, it's really rewarding to see the changes and how drastic that impact can make on someone's life. And it doesn't feel like much at all, but it can make such a great impact, and I think that's really nice. The other thing I find rewarding is when at the initial appointment, when people come over and it's like, so have you seen many of these FND patients and what's your understanding of it? And once we provide that understanding, just seeing the relief at that initial assessment, I find quite rewarding as well, knowing that they do have trust in our care as well.
Yeah, yeah. Okay, and the last question that we've got here, again, it's anonymous, but if there is an abnormality present during an MRI, is the radiologist and/or neurologist obligated to disclose this with the patient, or is it up to their discretion?
No, what's that, sorry?
I didn't know if you felt able to answer that question or not, so...
Well, I would like to think that ethically that there's a duty of care to share those results unless someone's been deemed not to have capacity of their own decision-making abilities, and if there's other legal measures in place. But yes, I'd say from a physio perspective, I would like to think that everyone would disclose things. And I know I work with a great team of neurologists at the Mater, and through Active Rehab, we see a lot of external to the Mater as well. And I haven't seen anyone withhold test results from anyone.
No, I would imagine that most people would get the opportunity to actually see their own MRI scan. So, I mean, as a layperson, you might not know, but obviously you're in control of asking the questions, is everything okay?
And I think it's also a really powerful part of therapy as well, knowing what's causing. So if there is something there that's causing these symptoms, but that can't cause these symptoms. So it just makes it a bit more powerful knowing that there's some bits that are caused by something underlying, or if there's nothing underlying, that they can plant that seed of really understanding that there's a problem with the function of the nervous system there. So that's just my opinion.
Okay. And the last question that we've got, and then we'll wrap up. But Alison has asked, my symptoms shifted from mostly movement symptoms to more pain sensory systems. Do you have any suggestions for working through pain or numbness or tingling sensations? I had one person mention nerve flossing to me do you know if that might be an effective treatment?
To be honest, I'm not sure what nerve flossing is, so that's something I'll probably have to look up. It could be something that's just relabeled as something different to what we use. But for both those symptoms, again, it's that desensitization of just trying to expose yourself in a graded fashion to the different sensations, but also exercises and movements that isn't painful. Graded motor imagery is great for that, and that's a physio technique and it's also a psychology technique as well that's used just to help that graded input into addressing pain. And so not all pain involves moving the limbs straight away. There's a lot of going back a few steps depending on how bad the pain is. It can start at just visualization exercises, and that in itself has a powerful role with lighting up the centers of the brain that affect the sensation and the pain systems in particular areas of the body.
Yeah. Okay.
So I guess the big message is a graded approach and making sure that it's prescribed for the right level, not over prescribing or under prescribing is a good start.
Yeah. Yeah. And we've got a couple of last minute questions that have just snuck in, and then we'll wrap it up. They're kind of related. The first one from Rhonda says, are the contractions of muscles reversible by regular manipulation? And then Tamara has asked, if you're in a wheelchair, can you still do exercises with FND?
I'll answer the second one first. If you're in a wheelchair, yes, you can still do exercises being wheelchair based. Even if you had no movement from head to toe, which are some of the extreme cases that I have seen, there are still exercises you can do. They're more visualization exercises, trying to reconnect the body and the mind together again. So there's always exercises when there's the physio involved, fortunately. And then the second question was, the first question was to do with contractions.
Yeah, contraction of muscles is reversible by regular manipulation.
Yes. I probably need a bit more detail and context with regards to that, but I'd more contractures that have muscle contractures or tightness that have contractile or non-contractile elements normally need a variety of input to be able to lengthen the muscle again. Grossly, I want to say no, but manipulation itself wouldn't relieve a contracture, but I don't want to rule out anything.
Yeah, I mean,
without the right context.
I mean, if that was in the case of dystonia that was presenting
Yes.
as a contraction, then normal physio manipulation isn't going to. Often the physio can't even move the limb that's in question, so it very much does depend on the context. Yeah. But
if it's fixed, you're absolutely right there that the physio pushing and pulling on it, I dare say, would make it worse. But if there is a moving component to it, there could be, if it's been there for a period of time, the joint could be stiff. There could be some elements there that could respond to some sort of manual therapy, but I'm very reluctant to say manipulating can reduce contracture.
Yeah. Okay. That brings us to the end of this Q&A. So
great questions tonight or this morning.
Yeah, it has been great. So I wanted to thank you very much. I mean, we've seen a lot of good communication with professionals like yourself, so we're very, very grateful. I think you've shared some good information, and I know people have been asking particularly about the bibliography of the paper from Glenn Nielsen and the other documents that you mentioned. So we'll get those separately from you, and we'll publish them to the website. And Julie Wright can make sure that our audience in Australia gets that through Facebook. And I guess just to close, it's kind of interesting when talking to professionals like yourself, but as a patient group, as FND Hope is, do you think there's anything more that as patients and as organisations such as ourselves can be doing to help create the awareness among the professional community that you're part of?
I think FND Hope has definitely pioneered the way in how much awareness and education is getting out there. there's very few of my patients that are coming through both privately and publicly that haven't heard of F&D Hope, and if they haven't heard of it, I know our team are very forward with making sure they're aware of the patient group as well. I think education's the key, and if the patient is informed and they know what they can have access to and not have access to, then they're more likely to ask their consultants the question. And even going and asking and saying, being familiar with the term F&D, just throwing it out there will force health professionals in general to know and understand the condition a bit more as well. Yeah. So I don't think there's anything more that F&D Hope can do, because I think these webinars and all the information and resources you provide to everyone is fantastic. But I think as a whole team that we still have to push for education, which I'm really proud in our team that we're able to do.
Great stuff. Well, Dharsha, thank you so much again for your time this evening.
Thank you for having me.
It's been great. Thank you to all our participants for the great questions that have been asked tonight. We will share this presentation up on YouTube very soon, so people will be able to view this again at a later date. So thanks again, Dharsha. It's been great.
Thank you.
Bye.